Hi, Mel. How you doing?
I'm well. How are you, Henry?
Good, good. Thank you for presenting.
Oh, no worries. I'm sorry I had to cancel last time at last minute.
No, completely understandable. Yeah, I usually give everyone to like 1:05 so they can log in and then we can start.
No problem.
All right. All right, good afternoon, everyone. Thank you for joining this session today. So today we have Melanie Willimann from Alberta's Children's Hospital presenting. Mel, thank you again for presenting, and you can take over.
Awesome. Thanks, Henry. Hi, everybody. For those of you guys who probably a lot of you don't know me, my name is Mel Willimann. I am the pediatric point of care ultrasound director at the Alberta Children's Hospital, which is in Calgary, associated with the University of Calgary. I'm also the co-founder of a pediatric ultrasound learning curriculum and platform called KidSono. We're totally non-for-profit and always looking for partners. So if you have any questions about that at the end, let me know. So I've just put together a few cases, fun cases that we've seen really over the last maybe one or two academic years here in Calgary, just to give you guys a little insight to what's going on. So this one was actually a case that one of our Peds Emerge fellows had. It was a previously healthy 7-year-old male who had moved from Somalia to Canada 1 year prior to presentation. He took no medications, had no allergies, his immunizations were up to date. He was really a healthy guy. But he presented to our emergency department with a 2-week history of nocturnal fevers, shortness of breath on exertion, malaise, and fatigue. The fevers were mainly nocturnal. There was minimal antipyretic response. He had preceding cough and coryza symptoms, probably the week before, and his mother described him as fatigued as interactive, but his fatigue was actually quite significant. The 3 days prior to his presentation, he developed significant shortness of breath on exertion to the point of he was dyspneic while drinking water and taking a few steps. He was still actually eating fairly well and had no history of bowel or bladder symptoms. The review of symptoms revealed there was no rash, no toxic ingestion, no trauma, no history of similar symptoms previously. Was really fairly a healthy guy. Little warning for those of you who went to the P2 conference a year or two ago, our fellow did present there. So on examination, his temperature was 37.9 in the emergency department. So, I mean, barely what we would call a fever. He was mildly tachypnic. On exam, he had an elevated JVP up to the level of the tragus. He had a grade 3 on 6 holistic systolic murmur of his left sternal border, and some hepatomegaly with his liver edge about 5 centimeters below his costal margin. His abdominal exam and cardiac exam and lungs exams were otherwise unremarkable. He had, some decreased breath sounds, but no adventitia. He at that point didn't have any stigma of endocarditis. So kind of given all that, he had some initial lab work, and my PEM fellow went and put the probe on his heart. And this is the first image he obtained. Anybody have any thoughts?
Looks like you may have a friend in the left atrium.
Left atrium or ventricle? Yeah, so my initial look at this was like, okay, well, his squeeze okay, his mitral valve was moving well. I said, the basal septum here looks funny, and there seems to be some kind of big goober on this, kind of in that RV there, which I wasn't quite sure of. But we said, okay, well, our big question is, is this a rheumatic heart disease in this new immigrant? Is this something, what's going on? So we decided to look. Goober, yes, it is a goober. So we decided to look a little bit more. So we threw some flow in that mitral valve, just to get a look, given the question of, rheumatic heart disease in this traveler. I was like, okay, well, he's got reasonable flow through his mitral valve. Perfect. And he didn't have big mitral regurg or stenosis. So we were happy there. But what we saw as we were doing this, that there was a lot of like chatter and flow over here that we couldn't make out. So we moved our box. Any thoughts on that? I'll play it again. It's a little bit of a noisy picture because he didn't bring in his color box nicely.
Is there a VSD? Sorry, we just jumped in late, but it looks like there might be a VSD.
I agree. And I mean, if you don't know his story, previously healthy 7-year-old who had immigrated from Somalia with 2 weeks of nocturnal fevers. So yeah, I agree, right? There seems to be flow. And in retrospect, when I go back to the image before, his basal septum seems to disappear sometimes and not truly connect. So we were starting to get quite suspicious that he had a VSD, but that also left us with, okay, well, what the heck is still going on with his goober on that right side? So this is kind of the closest we could get to a 4-chamber. I apologize, the left atrium's coming in and out a little bit. Any thoughts on what we're seeing?
This is Lay from Connecticut. I'm confused by the orientation of this view. I think the indicator is to the, presumably on the left side of the patient, but somehow the RV is overlying the indicator. So I'm confused.
Yeah. So to orient yourself, yes, the indicator is this side, but the RV is here, the LV is here. I think my fellow probably mixed up his probe a little bit. RA, LA. Everybody seeing the big goober nicely in the RV there?
Big time goober.
Big time goober. And it actually is flailing around with the tricuspid valve. We put some flow on that. Flow was pretty good forward, had a little bit of tricuspid regurg. So with this, I mean, we got his lab work back. His white count was slightly elevated. He was admitted to the hospital and he got a formal echo, which showed, given that he actually had an undiagnosed basal VSD. And in the context of his, poor dentition prodrome, he was found to have a tricuspid valve endocarditis secondary to his underlying VSD that had been undiagnosed. His blood cultures were positive for abiotrophia defectiva, which is apparently a fairly common bug causing endocarditis in those with congenital heart disease. He got 6 weeks of total antibiotics and finally underwent perimembranous VSD closure and tricuspid valve reconstruction. He did fairly well post-operatively, did develop a little bit of pericarditis, but otherwise did quite well. Has anybody else ever seen true vegetations on their POCUS? Because that was one of our first. We were pretty excited to see it. Or undiagnosed cardiac disease.
Yeah, hey, it's Adam from FBI. The more you do it, you're going to diagnose undiagnosed ones. I think Lay in the chat box is talking about cases that he saw from abroad programs, but a lot of times it's going to be patients like yours that come from another country and you don't really know what their health evaluation was prior to arriving into the Western world. But valvular lesions are going to be relatively uncommon in our native population. If you work with your adult colleagues, you're going to bump into drug users, IV drug users, or other pathophysiology that's going to lend to valvular disease. So it's always great for people to be able to go to those adult reviews and see these things every once in a while.
Yeah, no, I've seen a couple undiagnosed congenital cardiacs in the immigrant population for sure. It was fun to see a vegetation, and my adult colleagues tend to see it more commonly, but again, our population doesn't have a lot of valvular disease, so it was kind of fun. Perfect. All right. And since we're on a theme, we'll move on to this next case. This was actually this same fellow who really likes cardiac POCUS. He was actually working in the PICU on call at night. And he was called to assess a 16-year-old female who was previously healthy. She had actually been admitted and presented to the hospital 10 days prior with a several-day history of fevers, rash. She was COVID negative and a 24-hour history of progressive altered loss of consciousness. She was diagnosed with a mitral infective endocarditis, sat as post some dental work on a healthy heart valve, so she had no underlying heart disease. And the CT had shown multiple septic emboli with hemorrhagic transformation at that time. After some initial heart failure, she had stabilized quite well and was just receiving IV antibiotics and some neuro rehab on the wards. But on this 10th day after admission, she had a sudden decompensation on the ward with work of breathing, increased O2 needs, and some poor perfusion. You don't see anything because I don't write anything, I just speak. Yes, Canadians are very weird. I just find it redundant to both speak it and write it. So that's me. On his initial assessment up on the ward, she was afebrile. She was quite tachycardic with a pulse of 140. Her rest rate was 32, and her saturations were 92% on a 10-liter non-rebreather mask. Her blood pressure was elevated at 140 over 65, and her cap refill peripherally was slightly delayed at 3 to 4 seconds. She had a normal S1, S2, but a holosystolic murmur, loudest at the apex. She had fine crackles bilaterally with some moderate increased work of breathing, and her liver was about 4 to 5 centimeters. She was transferred to PICU, where our PEM fellow was on, and I actually happened to be on next door in the emerge, who obtained some images and called me as well as the intensivist at home. So this was his initial image. Any thoughts?
So you got something hanging on the mitral valve.
Yeah, which, I mean, she's got known endocarditis, but she does have something hanging on the mitral valve. Anything else funny about this picture?
Something hanging on the septum.
Mm-hmm. You wonder, right? We can't see quite well the septal attachment in the basal. Ladle sign. I like it. Does anybody find the motion of the mitral valve weird? That's what I kept looking at. Because that's the first thing I look at when I'm looking at function in a parasternal long. I look and, see EPSS by visual. And I said, well, it's moving really, really, really well and freely. And it's contracting well in this view. Does anybody find it's moving funny though? Because I did. If you're not sure, we did this.
Doing a bit of the worm.
So we became pretty convinced if you watched this for minutes at a time, that this mitral valve was actually flapping around quite freely, and we were wondering whether it actually had any attachments to its septum or whether we had a chordae tendineae rupture. Just because it was moving very weird, and given the clinical picture of her sudden decompensation on the wards after a 10-day period of relative stability. So obviously we did this. Any thoughts on that mitral valve now?
I mean, if you know there's endocarditis, you're going to get acceleration through there.
Yeah.
I like the 4-chamber views for looking at the chordae.
Yeah, I know. Unfortunately, we were unable to get a 4-chamber view on her, just given her dyspnea, and even getting around the left side, she was just not moving around well. So we were a little stuck with these images at the time. But definitely not a pure MR. It just looked like a complete mixing lesion with free forward and backward flow. And given our concerns of kind of what was going on in terms of the movement of the mitral valve and the known endocarditis, the sudden decompensation, we were really concerned about a chordae tendineae rupture. So we obviously took a look at her lungs, because given the majority of her decompensation was respiratory in nature, and her lungs looked like that. Very, very wet all of a sudden. So with these images, between me, the intensivist, we were fairly suspicious of acute onset CHF from a chordae tendineae rupture with acute free MR. Immediately in the PICU, we put her on BiPAP. We decided to afterload reduce her a little bit, and then cardiology came in. Of course, this was like 2 o'clock in the morning. Cardiology came in to do a formal echo, and they confirmed a chordae rupture, flail mitral valve. And at that point, since we are not a cardiac surgery center, our sister site in Edmonton does cardiac surgeries about 3 hours away. We packed her up in the airplane with our transport team, where she went quite quickly to the OR and had a prosthetic valve placed, and overall came to us a few days later, doing quite well. And she actually had a fairly good and complete recovery, including her neurological status. So that was a quite great case, but poor Bo. I know. I mean, this is a 16-year-old girl, previously healthy with a normal heart, who got some dental work, and then MSSA just destroyed her heart. But it was really fun in the middle of the night to have POCUS, where it's not just, kind of confirming suspicions, but it really trained management in terms of, we immediately started her on BiPAP. We made the decision to afterload reduce her, kind of from a cardiac physiology, to increase her forward flow, which I think was a really nice temporizing measure, since it, takes several hours for us to arrange transport and move her up to Edmonton. So it was kind of funny within the span of a year to have 2 kind of big endocarditis cases in the Children's Hospital with POCUS. That, COVID's had its hard times, but it was really fun to have all of that. Perfect. Okay. Moving on to kind of change gears to off the heart. And these were a couple cases that I have seen in the emergency through the last academic year or so. Some that were kind of a little funny and that got me thinking. So just wanted to share. This one is a 9-year-old female with worsening right flank pain, fevers, after multiple ground level falls over the past week. So she first fell skateboarding with her family about 1 week prior. She was winded and she had some right flank pain at that time, but it had mostly settled at home. 2 days later, she was playing with her friends on her friend's crutches, and she got hit on the right side, which kind of aggravated that flank pain that was there. And when she presented to us, she had a 3-day history of progressive pain and now actually had a fever. Her urinalysis showed large leukocytes, greater than 30 WBCs, as well as some small blood. Given kind of the story of these, maybe ground level falls and this right flank pain, decided to do a fast exam on her. This is her left upper quadrant, so not the side that has pain. Which, as you can tell, looks fairly normal. And that's her spleen tip. Again, fairly normal on that left side. And then this was her right side. And I took a while looking at this side. I mean, there was no free fluid, but just looking at her kidney, something kept catching my eye. And I'll play it a lot of times. See, does anybody catch it as I'm panning through?
Looks like cystic structures like in the parenchymal part of the kidneys.
Exactly. So not exactly what I was expecting. Kind of, I thought ground level falls of, this, she's got a fever. Now she's got, leukocytes in her urine. I was okay, this is going to be a UTI, but the family's really fixated on these multiple falls. So let's do this. And then I get this in her inferior pole of her kidney. So now I'm thinking, okay, is this trauma related? Did she have a urinoma? Does she now have, an abscess from a UTI? So I'm not really quite sure. It doesn't look like an abscess because it's, following the structure of that lower pole and that renal parenchyma there, as you stated. So I was a little bit questioning what was going on. Her bladder looked fine. No free fluid there. So I went ahead and got a CT because it was all a little bit funny. And this is what, there we go. So if you remember, it's that right side, that lower pole. We were kind of seeing the questionable areas. So this CT basically revealed a grade 3 renal laceration. With no urinoma or anything, just a straight up grade 3 renal laceration. So given the combination of the fever and the leukocytosis and the urine and then the new, grade 3 liver lac, she was admitted for observation. Her urine actually drew positive for E. coli. And a repeat ultrasound showed actually complete resolution of the focus. And yes, always so subtle, Alex, on sono. Yes, it was something that it just kind of catches your eye and you'd had to do 100 times, but I thought I was going to go in for a straight UTI. And then my ultrasound clearly changed my management on this case. Any questions? The benefit of always looking at so many normals. Yes, us in the peds world do a lot of normal scans that all of a sudden our eye catches those weird and wonderful things. Moving on. This was another trauma case, which kind of has two fun things and kind of emphasizes that looking at the normal versus abnormal. Is a 10-year-old male. It's the Great White North. He was sledding and he was a toboggan versus a metal pole. He was transferred in from an outside center. We're the regional center for about a 600 kilometer catchment radius, with some mild tachypnea, no work of breathing, but a distended abdomen and tender, greatest in the right upper quadrant and suprapubic area. They had actually already placed a Foley and done some lab work, so we got him as was. Took a look at him with the ultrasound as part of my first trauma assessment. This was his right side. He had a right-sided pneumothorax, but he was breathing well with just a little tachypnea and 100% on room air. This was his right upper quadrant. Anybody see anything on that? This one's less subtle.
There's some free fluid there. Looks like it.
Yeah, there's a strip of free fluid. And then also under the diaphragm, eye gets caught again on this irregularity of the parenchyma. I mean, the free fluid strip in a kid is enough to kind of push you one way or the other, but again, catching a parenchymal lesion on POCUS. His liver tip was a little bit more impressive in terms of his free fluid. His left upper. Fairly clear. We have a nice view of the parenchyma, which, you know, finally looks normal. Got to see that paracolic gutter. And then this was his bladder. Now, I will note that if you recall, I noted that he was transferred with a Foley in place. Where you can see his balloon there. And that he was tender in the suprapubic region. So that's his Foley. I asked the nurses whether his Foley was draining, just given the size of his bladder. I mean, he obviously, you know, has lots of free fluid, some clotted blood, given the time post-injury and transfer. And they said his Foley was draining, but his urine output wasn't great. And when they looked at his Foley, they had put a 6 French in this kid, which, if you guys don't know Foley sizes, is the size you would use for a neonate. So before we sent him over to the CT scanner to kind of confirm what our concerns with the liver were, we changed his Foley out, and his bladder decompressed very nicely, and you could more obviously see his free fluid and beginning of his clotted blood. So that was fun, just to see a huge bladder on the kid with the Foley and say, hey, let's change that out before he burst. He was very grateful. He actually, his abdominal pain improved greatly after we just changed out his Foley catheter. So his CT ultimately showed a small right pneumo, which we knew about. And as you can tell panning through, he also had a liver laceration. It was a grade 4 liver lac. And he did quite well. He was managed conservatively. His recovery was complicated by a little bit of a fever and a right pleural effusion, which both spontaneously resolved. And he went home a few days after actually he was admitted. He did quite well. So this is like, I had these 2 cases probably within the span of a month, and I kept wondering, well, how much do I need to CT these kids, right? I know you can use labs and as well as a fast exam and have a fairly high sensitivity, but how good is ultrasound alone in terms of finding this? Now, this is obviously a paper that looks at contrast enhanced ultrasound, which is a really actually kind of fun thing that's coming, and it's being used a lot in Europe, and we're talking about rolling it out at our institution in the radiology department, not as a POCUS tool, comparing the use of contrast and regular ultrasound, contrast enhanced ultrasound, as well as multimodal CT in pediatric trauma patients. And the question was really, what is the accuracy given the non-operative shift in management and no clear evidence for kind of rest return to activity guidelines? Do we really need CT? This reviewed 73 children who presented to an emergency department between October 2012 and 2013 with a history of minor abdominal trauma, and who underwent both ultrasound, contrast enhanced ultrasound, as well as CT. Inclusion criteria were ages like 0 to 16, hemodynamically stable patients with a history of minor blunt abdominal trauma. They were excluded if they were hemodynamically unstable or a history of major trauma. and just wanted to look at kind of sensitivity, specificity of regular old ultrasound versus contrast versus CT. And for those of you who have not seen, this would be a regular ultrasound image of what, you know, a lesion would look like. Contrast enhanced, that brightens up that really, really nicely, which corresponds to your images on CT of contrast versus regular ultrasound. So the results of this study, which, I mean, they found a significant amount of injuries. Only six of the 73 patients were negative at all three scans. The ultrasound alone, so plain ultrasound with contrast, only detected 26 of the 67 parenchymal lesions. So definitely a substandard test there. But when you add contrast, those identified 67 of 67, so 100% of the parenchymal lesions, including 21 of the liver, 26 of the spleen, and 7 lesions of the kidney, or actually 20 lesions of the kidney when you include both left and right-sided. So the diagnostic performance of contrast and enhanced ultrasound was obviously better than plain ultrasound, but its sensitivity, specificity, positive and negative predictive value is actually 100% for all scores. So it was very interesting to see that there might be, you know, one day an alternative for CTing all these minor traumas, particularly when they're stable in the context of very little surgical management of these patients. Interestingly, contrast in enhanced ultrasound also had identified most prognostic factors for active bleeding in 8 cases and partial devascularization in 1 case. So it was quite accurate in identifying kind of the concerning features. Does anybody use contrast enhanced ultrasound at their site? Does anybody have any experience with it? We wish. Me too. They were studying it at CHOP when you were a fellow there. Oh, Lauren, interesting. Yeah, I know there was, I think CHOP had actually done some kind of lectures about it in a lecture series. I just haven't really seen it yet make its way into the literature or use. So in this study, yes, radiology was performing it. So this is something that, you know, maybe 20 years down the line would be in the hands of POCUS users. But to me, even to have this in the hands of radiology for these, you know, stable minor injuries, low-grade mechanisms, it would be really nice as a follow-up to have a contrast enhanced ultrasound as opposed to having to CT these children. It was the RADS and POCUS team at CHOP, but not yet in real time. Yeah, okay. So we're not that far behind the curve in terms of nobody else is using this routinely. We're always looking for ways to get rid of CT scans, obviously, in children. And this I wonder is really a good place, I think, to start. But yes, even though I can find all these lacks, you know, slowly now I'm starting to identify them on POCUS on my FAST. I can't rely on that. So I'm still doing blood work. Our protocol at Children's includes blood work and a FAST scan. And if both of those are negative, we can often avoid the CT scan. And even our surgery team colleagues at this point will admit some of those children for observation. And if they're improving the next day, send them home without a scan. So that's nice, but it would be nice to decrease the admissions for sure. Perfect. Okay, got another one for you guys. So this one was a 14-year-old male. He presented with a 2.5-week history of right upper quadrant pain and 3-day history of progressive jaundice and pruritus. It was actually the itching that brought him in mostly. We noticed he was jaundiced. He had traveled to India 1 month prior. He was COVID positive on arrival 1 month prior from India. He had stayed in cities, had some home cooked food, bottled water. He did not have pre-travel vaccines prophylaxis, but his immunizations were up to date, including hepatitis B from his grade 9 immunizations. He was briefly unwell in India for 24 hours, but recovered quite quickly. Examination wise, he actually looked quite well. He was afebrile, he was jaundiced for sure. He had excoriations all over his body. His right upper quadrant was quite tender, and his liver was palpable below his costal margin. So we're thinking a lot of things. Is this something post-COVID with him, being positive a month ago? Is this, a hepatitis? What's going on with this kid? So we threw on the ultrasound while we were waiting for his labs. And this is what we saw. Any comments? There's more images, obviously, but as we scan through. Jacked up gallbladder. Yikes. Yeah. That was my reaction. I was definitely not expecting this, given, we didn't have any of his labs back yet. And his travel history, I was expecting something that was going to be just, slightly bulky liver. Didn't expect that. So if you see here, we couldn't find his extrahepatic gallbladder, but intrahepatically it looked fine. His gallbladder though just looked massive, but it was empty. We couldn't really see any evidence of stones or sludge, but it was probably one of the nastiest looking gallbladders I had ever seen. We didn't throw down and measure it, but if you look at it, it's probably over 1 centimeter in wall thickness, and just looked bulky and nasty. Send EBV titers. We sent all kinds of things at this point. We had done some, basic LFTs and liver function initially. After this ultrasound, obviously we got a few more brains, and ID got involved, and GI got involved. It got some more imaging, but ultimately this child ended up having plain old hepatitis A. So when we got this back, I had never heard of or seen a gallbladder like this in Hep A. But there's actually, a little case series that has been published that there's, some reports of gallbladder involvement during such infection. And in this case series, there was about 75 children, average age of 4, who had confirmed, hepatitis A infections. They all were pretty much jaundice, but about 40% of them had visible involvement of the gallbladder with wall thickening greater than 3 millimeters, while 6 met the criteria for acute calculus cholecystitis. So there was no actually clear link between your level of transaminitis and your gallbladder wall thickness. But it really kind of hit home and concluded in this case series that ultrasonic examination should be carried out in each case of hepatitis, of acute Hep A, and should be performed with great caution if there are changes in the gallbladder walls. All these kids actually ended up kind of recovering well and doing quite well, though. So next time you have a kid with jaundice and you see a big, bulky, nasty gallbladder, we went down obviously the acalculous cholecystitis route, covered him with antibiotics, got MRCPs, the whole meal deal, but in the end ended up being a straight hepatitis A. Wacky case. He did great. He actually went home like 3 days later because he was feeling much better. This was the last one. This was a fun one I saw over the summer. Who just, again, POCUS made a big difference to my day. This was a 7-year-old male. He had a 6-month history of left ankle pain, like status post a really remote injury. He had fell riding his bike kind of 6 months previously. He had an abrasion and laceration kind of over that ankle that was cleaned and sutured in an outside urgent care. It was complicated by a local wound infection that was twice treated with oral antibiotics, but that was more than 3 months previous. And since that time, he had had an ongoing limp and ankle pain. He had seen his family doctor, he had seen physio, they had done, multiple repeat x-rays that just showed some soft tissue edema. But over the last 2 weeks, they had increasing pain and swelling really of that left ankle. So they came over to Children's for a second opinion. As it always seems to be, it was about 1 o'clock in the morning or so when I saw this poor family. And overall, he actually looked quite well. He had been afebrile and had been afebrile since, early on, for months. His vital signs were within normal limits. His left ankle showed maybe some, slight erythema compared to the right. It was warm and quite swollen with significant pain on range of motion, but he was a trooper and he was able to limp around and weight bear with an antalgic gait. So kind of wondering what was going on with this very acute on chronic history. I got some lab work, obviously looking for any evidence of infection. I said, I don't know if there was an abscess remotely from this wound, whether there was a pocket or something else. He actually had a normal CBC. His CRP was just mildly elevated with 15, which less than 12 at our institution is normal, so really mildly elevated. His ESR was also mildly elevated at 35 with less than 20 being normal. So Kocher criteria, like from septic arthritis, he was technically weight bearing. He had quite an antalgic gait. He was never febrile. His ESR was only mildly elevated and his WBC was not elevated. So he was actually 0. So I obviously got out my probe and put an ultrasound to this ankle saying, well, if there's a big effusion in his joints or is there a big abscess, this is going to, change what I do for this family in the middle of the night. And this was, sorry, I didn't catch a video. I just caught stills this night. So this is, you can tell, this is his distal tibia, and this is at the top of his talus here. As you can see, there is a big effusion of this left ankle. And as I scan down it, you could obviously, as that kind of talar dome comes over, you could see kind of the effusion and fluid. But what also caught my eye was this on top of things that I didn't really know. I couldn't think. I said, there's no anatomy that I can tell there. I mean, obviously we have some tendons and cross section, but I couldn't really figure out what was going on there. Yeah, you wonder, is there is there a tendonitis here? The tendon itself looks maybe a little bit bulky, but what is this thing? So I mean, given he had a big effusion and he could barely weight bear, I went ahead and I tapped this ankle. He was a very lovely kid who just with a little bit of topical and some nitrous allowed me to tap his ankle at 7, which was pretty impressive. And when I got the tap, I got frank pus from his ankle. I mean, it was one of the nastiest taps I've seen. It looked like purulent rhinorrhea. I consulted ortho, and an MRI confirmed a foreign body and a complex septic arthritis with a positive reactive myositis and extensor tendinitis. So in retrospect, this was probably a sliver of wood that had been in there from his initial injury 6 months ago. And when they went back and really asked about this bike fall more, I mean, 7-year-olds don't tell you too much. He had fallen against and kind of into a wooden railroad tie. So when he was originally stitched up, there was not a great story of a foreign body, and I guess nobody explored the wound too much. So he was stitched up with this foreign body, which probably got recurrently infected and was probably sitting around causing the chronic symptoms for 6 months until the last 2 weeks where he got worse, where probably that's when his septic arthritis kicked in. He was ultimately obviously brought to the OR. They had a complex fluid collection there. The foreign body was removed. He was washed out, and his culture from that joint actually grew positive for enterococcus. And he's being closely followed for orthopedics for a concern of early onset arthritis. So that was a fun one where you really do wonder whether we need a new kind of culture criteria with ultrasound now in terms of getting things more accurate. I've definitely had a few cases in the past few months as well where it's query osteo versus septic arthritis, where we do the ultrasound and there is no significant infusion there. Save the kid the tap, get advanced imaging. And the majority of those have been found to have, distal osteos as opposed to septic arthritis, which makes a big difference in their management. So.
Hey, sorry, going back to the ankle case, did you guys get any CT or plain imaging?
So I hadn't gotten, he had probably 3 or 4 x-rays over the 6 months. So I didn't do an x-ray. And given my concern of kind of the septic arthritis in the foreign body that hadn't been seen, I went straight to MR, which they did a few hours later.
Was there any bony destruction that was noted? I mean, because at least on these ultrasounds, the bony architecture looks pretty clean. And on some of these cases where, septic arthritis has been longstanding or an osteo, you'll see like periosteal elevation.
Yeah, so actually his bones were clean. He had a lot of reactive myositis, some tendinitis, and kind of the joint was involved, but the bones were clean on his MR. And MR is also our initial screening tool for all of our osteos as well. So the bones were clear. So I hadn't that night chosen to proceed with a plain film because it wasn't gonna change my management knowing I had tapped the ankle and pulled out frank pus.
Is that odd though, that there would be this long-standing chronic inflammatory stuff sitting in there for so long without bony destruction? Like, did ortho make any comments on that?
I think the chronic symptoms there had to do with the fact that he had a retained foreign body. It was like a 3 centimeter piece of wood, actually, 3 centimeter by 1 centimeter that was kind of lodged in his ankle. So I think he probably had initial wound infections, probably around the foreign body, and then had persistent symptoms there. And then in the last 2 weeks prior to presentation, that's probably when it had spread and really gone full out into the ankle joint, causing a septic arthritis. But I mean, this is all, guesswork and putting things back. But I mean, you would imagine if you had a chronic osteo, yes, we would have seen something on x-rays throughout, that you would have seen something on the MRI in terms of bone signal changes. So it kind of piecing it together, we kind of just figure that, he had a foreign body, probably recurrent focal infections of that eventually spread to a septic arthritis, which allowed us to kind of get to the bottom of everything. Perfect. Any questions?
Oh, that was great, Mel. Thank you so much. Great cases.
Thank you.
And thank you everyone for joining this week, and I'll see you guys next week. Thank you again, Mel.
That was great. Thank you.
Thanks, guys.